So, Dena, thank you very much for being a part of my doctor's encounters, because there's so much great information that I'm having the privilege of learning from all of you, and having you here is a great honor for me. And if you could just introduce yourself, give us a little sort of background on the work you do and how you got into this and what you're doing.
My name is Dr. Dena Harris, and I have been in obstetrics and gynecology since the 1980s. So I've been doing it for quite a long time and watched all of the evolution and changes. And in maybe the last 10, 15 years, I've become more involved in the menopause, but also hormone replacement in general, and as well as a lot of pelvic pain work. So that's been going on.
Okay. So you mentioned all the changes. Tell me a little bit about some of the biggest changes you've seen in your world since you started to now.
Yeah, well, almost everything's changed. But in the field of hormones, it's very, very much expanding. It went from everybody being on hormones to nobody being on hormones to us being a little bit more careful with the way that we do it, and different options for hormones. So that's been kind of exciting. And in terms of pelvic and sexual pain, which was ignored for, I think, the last hundreds of years.
Yes.
There's actually huge advances, and there is help out there for any women who think that there isn't. It isn't just in your head. Mm-hmm. There are medical conditions that cause it, so there's a lot happening in that field.
So I think hormone replacement, as you said, has gone through, ins and out of fashion, right? It was in to do it, and then it was out, and obviously it's an individual situation, but what are your, first of all, what kinds of hormone replacements are there out there? Like, what are the different types? If you can, I don't know that everybody is really educated about this, so we would like to know everything.
Okay. Well, for hormone replacement, which basically means that you no longer have hormones for whatever reason and need to replace them, the way I put it is there's three different types. There's synthetic hormones, which are hormones that are made chemically, usually by the pharmaceutical companies, and they're not what we call bioidentical. Bioidentical hormones, which is another type of hormones, are hormones that have the same molecule that your body makes. So it's possible that pharmaceutical companies, and they are making them right now, and also there's others that are more compounded, which is the third type, which is called compounded bioidenticals. Some people call it designer estrogens, which basically means that we're taking a little bit from column A and column B, and based on some of your blood tests, and making the hormones fit the individual person. So those are the different types of hormone replacements that are out there right now.
So when you started to talk about the different types, you said when you are no longer menstruating.
Right.
So would it ever make sense to, making this up, I have no idea, would it ever make sense to start hormone replacement earlier through the menopausal experience to sort of reduce the transition?
Well, we do that a lot.
In
the perimenopause, and that can start for years. That can be for years. We do hormone type replacement, depending, of course, on the person, to try to ease them into the menopause.
Really? And so, I've never heard of this. Is this common practice?
I think the problem for doctors with hormone replacement is there's something called standard of care, and then there's non-standard of care. So standard of care is what the American College of OBGYN and NAMS, the North American Menopause Society, deems standard of care, and then there's other ways of practicing medicine I don't know if you would call it more creatively, as
And
long
so-
as you do no harm, of course.
And this is on the more creative end of it?
Yeah, I would say it's a little more on the creative end.
Well, I mean, I just think it's an open door for a lot of exploration, because the transition period for women in menopause is very disruptive. I mean, it's like, it's more than a snake shedding its skin. It's an emotional, spiritual exchange with, the past and the present and the future. So how does that work when someone
Right.
is experiencing this and they're a candidate? What would make someone a candidate?
If somebody is on perimenopause, for some women is the worst part of it, not really the menopause. Once they're there, things have stabilized and they feel much better. So for some women emotionally, especially, the perimenopause can be really, really difficult.
And peri could start,
In your 40s, for some women in their 30s.
Really?
Well, it depends on when they're going through the menopause. So, and there's many different ways to approach that. There's a group of doctors that use the standard of care method, which is birth control pills, which, by the way, is people have very different reactions to birth control pills when they're perimenopausal, as opposed to when they're in their 20s. So somebody who might have had a really rough time in their 20s emotionally on birth control pills would do fantastically on birth control pills in the perimenopause. So there's that. And
so
then
you could experiment with that then.
it helps a lot of people. For some women, their cycles are so up and down and all over the place that the only way to do it is to suppress the hormones that they're actually making, which is what the birth control pill does, and then add back. There are other even more extreme methods, which I use very rarely, but like to actually shut somebody down with Lupron or one of the newer drugs, and then add back hormone replacement so that you actually put somebody into the menopause.
Wow, interesting.
Over the years, before we had these drugs, there were women that would beg to have a hysterectomy or have their ovaries removed because they couldn't stand it anymore. These are very extreme cases. It's not, for those out there, it's not always this bad.
So there, I asked my staff to, mostly women, I asked them to submit questions that they never have asked and would like to ask. And so one says, I've been on birth control for 30 years. Is this really bad for my body? I'm 47 years old. So obviously she's going to be going into menopause. Does she continue her birth control?
Well, if I were taking care of her, yes, I would just keep her going until she started to have signs of full menopause, which is really hard to tell.
How would she know?
Well, sometimes people are on the pills that are 7 days off, and they start getting bad hot flashes those 7 days. Some women on birth control pills later on might experience vaginal dryness, and I begin to realize that they're actually more menopausal and that they need really more hormone replacement therapy. But if we don't know, I go 52 and let's stop it and see what happens. And usually I'll run some hormones if it helps, and if they stop having their period and no longer having their period and want to go on hormone replacement, at that point I put them on hormone replacement.
Interesting. Obviously, hormones are just an incredibly important part of a woman's life, from puberty to post-menopause. They literally have such a control over our behavior. In many cases, we don't even know why we're behaving a certain way, and it's almost like we're being taken over, or something bigger is creating a behavior that we know we're not comfortable with. And we keep all of this conversation pretty quiet because men have used it as a reason why women are incapable of doing certain things. And so I've never found it a point of conversation that I wanted to bring up anywhere, except I want to bring it up in this day of interviews, because I don't feel good about anything that owns me, that I can't control. And from puberty to postmenopause, in my life experience, I understood when I was objectifying myself with men, maybe, and I wasn't like a trollop or anything, but I would find myself, for wanting to be loved, this overwhelming need to be loved, wasn't with the personality that I normally had, but I would allow myself to be objectified and be humiliated and embarrassed, and know that intellectually that's not what I would do, and I would behave that way. And so I'm saying this because I'm wondering if there, and obviously that's part of the process of attracting men and women together to procreate and many other things, but I'm wondering if there isn't, now that we have a sense of these bioidenticals and hormones that feel safer and are more connected to behavior we want, if there isn't some way to look at the roller coaster women go through in their entire history, from that puberty experience straight through and having a baby and all of these ups and downs, if there isn't more information that is out there or you see on the horizon that could give us a little bit more control over the fluctuations.
I don't know if there's anything out there that's going to change this. I don't see it as, I think we just have to accept it as not a bad thing. And
well,
if women feel more empowered, and I think as a mother with a young daughter, I don't know how successful I was, but I made an attempt to make her feel more empowered. I think that helps.
Yeah.
But I think that some of the hormonal changes are wonderful. But I do honestly feel more powerful in the menopause than before the menopause. And so it is a really freeing thing. And now that we're living a much longer lifespan, the menopause is only halfway through, I think. So we've got another powerful 50 years to go.
I'm so happy you're saying that.
Yeah.
And so why what can you tell a woman who's going through the throes of that experience of realizing that she's sort of shedding a skin and going into another period of time? First of all, what are you doing that makes her more comfortable?
Well, from a medical point, I mean, the birth control pill does settle a lot of, I've been bringing it up a lot,
but that's a great
it does
point.
Settle a lot of women who are very emotional because it keeps them at an even keel. And a lot of the millennials are on birth control pills, and I think they're with all of what they know, I think they're a very powerful group from what I can see. So I do think it helps, but I'm not sure there's much more that we have unless we do some really so crazy.
Yeah, but that's something that is a tool now that I certainly didn't look at as an opportunity to make the transition for me easier. I think, and so once that transition happens, and we want women to feel as good about themselves as possible so they understand that reinvention at 50 is this great new opportunity that they can really enjoy. And that, I mean, I'm 74, so I certainly do not see to me, it couldn't have been better for my life. Everything I feel is just getting better, and I'm not just saying it. I believe it heart and soul, and I'm so happy for the opportunity. But I think having these tools, so if birth control can help with the transition or getting to it, and then bioidenticals or other more evolved hormone replacement can sort of make a woman feel at her best and look her best too. Obviously, that when you look in the mirror, if you think you look good, you can a woman can just take over the world. So having that empowered feeling is a big deal. So for women in general, and the whole hormone replacement conversation, what would you say in general as something for women to think about, and what that would do for them?
Well, there's definitely advantages and some disadvantages to hormone replacement, and I do think you have to take it very, very individually. And I think that's where it's evolved to at this point. And so for some women, it really isn't a possibility because for medical reasons they can't do it.
Which would be?
A significant, having had breast cancer, a significant family history of breast cancer, the BRCA gene, genetic, they have clotting disorders that they can't really be on estrogen, although there are other things that they can try. So for those women, it's not a possibility, but you don't have to have hormone replacement to feel good about yourself. So it's not the only way.
Right. And so what are some of the other suggestions?
And for not hormone replacement.
Yeah.
Well, if there's other medications for hot flashes
And what are those?
they're doing a lot of the SSRIs, which are the antidepressants, the Effexor, gabapentin. They really help with hot flashes, especially with women who are really suffering. It's not as great as hormone replacement, but it does work. There are other side effects, but there are side effects to hormone replacement. I have a group of women who can't tolerate hormone replacement, whatever I put them on.
And what happens when they try hormone replacement?
Some women just feel
sick.
terrible on hormone replacement, but that's an unusual group.
Yeah.
So.
And so if how long is there a specific amount of time that hot flashes occur, or because it's not necessarily the full length of the transition, obviously different things happen. Is there a typical hot flash time?
Well, some women start in the perimenopause getting hot flashes, but generally most of hot flashes start within a couple months of not getting your period or the menopause. And for some women, they last only 6 months and then they're fine. And for other women, it's 20 years. but the worst part of it is the first 5 to 10 years for those women. And it's usually like the experience of taking off like a rocket and being miserable and being in a meeting and, having a flash or feeling even faint. So those are usually around just the first couple of years when it's that bad. If somebody's getting it for more than that, 10 years, it's usually they're a lot less intense, but they're bothersome. Those are women that often stay on hormone replacement for that reason alone.
Is there a deadline for how long you can be on hormone replacement?
That's kind of like the $1 million question. But if you ask Medicare and the government...
No, I'm not.
They say at 65, there's an increased risk of stroke and heart attack, and they recommend that we take people off of it, but I haven't been, because I do think that for some women there's tremendous advantages to being on hormone replacement. I have 80-year-old women on hormone replacement. They look great. They feel fantastic. A lot of them are still working. I don't know why that goes hand in hand. So I think you have to take it very individually. For some women, it's not a good idea, whereas for other women, it's helping they have a terrible family history of osteoporosis, and it's really helping their bones, and they don't want to go on the biphosphonates.
Yeah, that's what my whole thing is my bones, and so I immediately made that a part of what I do, and I never feel like I'm flexible, but if I'm told my bones aren't good, I'm going to have to do whatever I can. And I think that having that as a choice gives me the opportunity to make the decision. I also think it's good just overall well-being, but knowing that my bones are very much an important part of how I age, you make those choices, and like you said, it's totally individual. So the chemistry of what's in these hormone replacements, like what is in them beside, is it just hormones? Is it just something that mimics the hormone, or is it a combination of things? Is it like,
Depends on which one you decide to be on. You have to, work this out with your doctor. There's the synthetic ones are generally estrogen is the estradiol, so that's actually bioidentical. So most of the synthetic hormones, the estrogen part is actually bioidentical, but Premarin, which is an interesting product, is conjugated estrogen, so it's a mixture of different types of estrogen and isn't necessarily bioidentical. And the progesterone part is the part that's often not bioidentical in the synthetics. So now they might put in a progesterone that is used in birth control pills like norethindrone. They used to use in Prempro the Provera, which I personally don't particularly like, and I hope that anybody on Prempro isn't upset. That's just my personal preference.
But it's important to...
Yeah, and but there's been most of the studies have been done on Prempro, the Women's Health Initiative studies. And then there's a bunch of newer stuff out. Something can I do a V?
Sure.
Duovi is I think a very interesting synthetic product. It's Premarin, which is the conjugated estrogen. It's totally synthetic, but and then there's the progesterone is a SERM, or selective estrogen receptor modulator, which basically is estrogen-like. And the reason that they did that is the reason you have to use progesterone medically with the estrogen is to keep you from getting endometrial cancer. So the progesterone protects the endometrium, but now they're worried that the progesterone is actually the cause of the increase in breast cancer in the Women's Health Initiative studies. So they made a SERM, or selective estrogen receptor modulator, that decreases the endometrium. It works on the endometrium to make it thinner. And so this particular one, there's a group of doctors that feel it's super safe because it doesn't give them breast cancer, but that it's still new, and as with anything, you have to watch it. I wonder if that one causes vaginal dryness. I have a couple people on it that are having that problem.
Which was my next question. What are some of the side effects of the different types of hormone replacement?
It's it's each one is, you have to know when you're doing this, you have to know each one. But the bioidentical ones are kind of interesting. Now the drug companies are making the bioidentical ones, so you have options of gels and patches and sprays, and they like you to do it transdermally, the estrogen, because it causes less clotting and less problems with heart and stroke, and they think. So
patches are
really nice because it's twice a week, but some people are allergic to the adhesive, or the patch doesn't stay on, but often they're very, very convenient. The problem with the patches is that the one that has estrogen and progesterone in it is a very, very large patch, and the progesterone in that patch is not bioidentical, because progesterone is like an enormous molecule, so it's really hard to make it as a patch. So a lot of people will prescribe the estrogen as a patch and the progesterone as an oral pill or a cream or whatever, or a vaginal cream, or they say put the patch on and put an IUD in. The IUD is not bioidentical, but it does protect the endometrium.
Wow.
So there's a lot of different...
Wow.
And then you have to know the little innuendos, like generally if you're lacking energy, testosterone can give you that, so you might want to add a little testosterone, but it's tricky. really
a cocktail of what each individual person needs for whatever it is they're
When I see someone, I listen to the problems. If their complaints are a certain type of complaint, then I go in that direction. If I can't figure it out, I start doing blood tests, which sometimes helps, and honestly sometimes it doesn't help at all. So it just depends on what the person needs and how they react to it. A lot of people, once they start hormone replacement, they feel fantastic.
Yeah.
It doesn't matter what
Yeah.
it is.
No, it's true.
So, in fact, most people, you don't have to tweak it at all because it's just like the best thing that ever happened.
So it's very interesting because another sort of statement about why past 50 is actually good. So now, if you do have a hormone replacement cocktail that is working for you and you feel fantastic and you don't have the hormone roller coaster running your life, you have absolute control over the way you decide to, live the rest of your life. You have absolute control over the decisions of what your purpose is in this lifetime. You've passed raising children, you've passed sort of the duties, the women's role, the required kind of life that we all think about as being women. And then you come to this point where you really do have the opportunity to do whatever you want, and through chemistry or whatever it is, to give women the freedom to feel good again and not have it be up and down and erratic and, like I was saying before, create behavior that you're not quite sure about, or you found an irritation and like, why did I say that, or why was I so explosive when I'm not an explosive person, or what was going on. And now you're more level and you're more sane and your decisions are rational and you're sensible and smart and reliable and dependable in a way that you could never have been before. And you're smarter than you ever were. That, to me, how do you describe anything better than that? And
so for anybody who's worried about the menopause, forget it. It's
well,
great.
but that's the point that I really want to make, and I want to say that if there's a chance to see someone like you or to get good advice personally about what the prescription is for each and every one of us, mine is my bones. I need to do, and I'm getting the plus benefit of everything else. And I go get checkups all the time, and I'm on it. But the opportunity to have this much time to be totally free to do whatever you want, I mean, come on, that's so appealing. And so every dream you might have had and everything that you can do can be for you, that it can be about you. It can be about self-love, and people really like people who care about themselves. They're not so nice to people who aren't good to themselves. And so any illusion women have about this being a not good time, they have to dismiss the idea of being appreciated for the way they look only, and that men aren't whistling or whatever it is, that preconceived notion of what a woman should look like. And I think you look better when you feel better about yourself. And when you sound smart and you're productive, that's very appealing. That's very powerful. So I think with the information you have and the power of where we're going, and I think it's moving so quickly. So my next question is, what's on the horizon? What do you see on the horizon in this kind of concept and work? What do you think is the next thing that's coming?
Well, I do a lot of sexual pain. So I think that's a newer field. I think we're learning more and more. And I think that's we're getting better and better at fixing the problems. And for younger women who have it, it's devastating. It's really can ruin someone's life.
What's a typical situation. I'm not really that familiar with how.
Right. Well, I do a lot of work with vulvodynia, pelvic pain, pudendal neuralgia. These are kind of hush-hush problems women don't talk about, but there's a lot of women who suffer from it.
So explain them a little bit more.
Well,
it is hush-hush because...
Very hush-hush. If a young woman might not be able to have intercourse because it's just way too painful, and it may not have anything to do with her psychology. It just might be that the tissue isn't working right. And that can be pretty devastating, and a woman can be perfectly okay, and then after something happens, an accident, a back injury, a hip injury, or anything related to that, suddenly be in tremendous pain. And if she tells somebody about it, because it's so private, people think that she's just nuts and crazy, and
or it's a mental issue,
right? And not what it really is, which is a medical problem. And then in later life, the menopause can cause, for a lot of women who choose not to be on hormone replacement, which is also a very good choice. They can be in pain and not feel that there's any help out there when there really is. A lot of it is just going to someone with the experience of how to fix it, instead of, listening to the person that you loved as your doctor for many years who can't help you with that, but they just don't know about it, that's all. And instead of them referring someone out, they just sit and suffer with it. So
what are the solutions? What are some of the more common solutions to this type of a problem?
Well, for younger women, there's help. There's real help. There's substantial help, and they should seek someone who knows how to do this. And they're all over it's over the internet, who they can go to, and they should not give up. But one of the easy fixes is, unfortunately, and some of the birth control pills, and I'm not exactly sure why, can cause severe vaginal dryness and pain. And all they have to do, and I'm probably going to get screamed at for this, but all they have to do is go off of the pill and give it 3 to 6 months, and they will probably be much better. So I'm saying it out there. Please try it. It could be something that simple. A lot of the younger women love the birth control pill because it's such a convenient, they don't get acne, their periods don't bother them. Some people don't bother getting periods. It's a wonderful method, and it's free, absolutely freeing, but it does have some side effects, and one of them can be this. So the IUDs do not cause this problem, including the ones with hormones: Mirena, Skyla, Kalina, Liletta, Paragard. They're all okay. So that is one particular quick fix. The rest of it, you really need to go to a doctor because they need to figure out what's wrong. For women who were perfectly okay and then had a problem, there is also, for the younger women, a surgical solution.
Oh, really?
Yes, and which is 93% effective, but it's a really big deal, and I wouldn't go in that direction first. I would try all of the other options out there. For women who just had a baby and who are breastfeeding, breastfeeding causes vaginal dryness. Please ask your doctor for some vaginal estrogen to place in the area that it hurts. Don't put the estrogen way up. It's got to be where it hurts, which is at the opening. So if they're uncomfortable with doing that while they're breastfeeding, that's fine. Don't panic. It'll go away as soon as you stop breastfeeding.
Really?
Right. Well, maybe 6 months. It takes 6 months for the vaginal tissue to get better.
And then in menopause,
And for other women who suddenly have developed a problem, they actually need to. That particular group has to go to the doctor if they have, especially with the very serious vulvodynia and pudendal neuralgias. They need help, and there are doctors out there Just look on the internet. There's tons of them now.
And is this something that can happen, or?
Yeah.
Yes. Is it hereditary?
For some women, they have a hip injury. It's the way they walk. Their feet turn in. They end up having a tear in their labrum. It has to be repaired, and then the vulvar pain goes away. For other women, it's a lack of estrogen early on for whatever reason. I already mentioned birth control pills. It could be even the hormone replacement that you're on might be doing it, or some of the breast cancer treatments can do that. So, of course, the people that are treating you for breast cancer should be able to address it, and there's newer stuff out, and those doctors actually generally know about this now. They're not, they're being trained and understand that that is an important priority. And then there's the menopause, and for some women, hormone replacement does not help. It's not enough. And so they need particular therapy locally to the area.
Topical.
Usually topical estrogens, again, not all the way deep inside, but more at the opening. So if your doctor gave you Vagifem or some of the suppositories that go high up, you could try not to put them up so high. That might work a little bit better, or to take a cream and actually put it at the opening at the same time, vaginal estrogen cream. And then for those women who don't want to use estrogen, there's a big thing right now is hyaluronic acid. There's the Mona Lisa.
Why?
It's works on the collagen. It just helps. So some women, especially if they're already on hormone replacement, a little bit of that might be enough. And some women really swear by it. They say it's great.
Really?
Yeah, but it's not always the thing that works. It's worth a try, though. Actually, I don't even think you need a prescription for that. You can probably call a compounding pharmacy yourself and get it. And then there's the Mona Lisa. Everybody's talking about that.
What is Mona Lisa?
It's a laser treatment to the vaginal tissues. It's been on all sorts of programs.
I'm so out of the loop on this one.
And again, it replenishes the collagen and is supposed to be good for vaginal atrophy and pain.
Wow.
And then there's other DHEA, I think some of the newer stuff that's out. And these things all work. They're great. They're really great.
Fantastic. Obviously the ability to be in control and get help is a big deal. I think having good doctors and access to good health care is really so important. And for women, we have so many reasons to see doctors and to be regular with our visits and to really be on top of our health, not only because we're the nurturers and we're taking care of people, but I think it's empowering to do whatever you can for health. How do you see healthy lifestyle and this sort of the transition, through menopause and going into making decisions about what you're putting in your body and how you're doing that? How are doctors talking about lifestyle these days?
Well, I think more and more doctors who are gynecologists who do what I do are more interested in the menopause than they used to be, especially the ones that have been working for a long time.
Yeah.
And their population of patients who are usually the same age with them. So they actually have formed organizations just for menopausal issues as women age. And so now they have the North American Menopause Society and a few others so they're actually paying attention to it, because before it was like, oh, well, you're in the menopause.
That's, sorry.
So that's a kind of a wonderful thing that's happened, and I think that's the contribution that our age has made.
Yeah. No, it's great. And I also think being conscious about sleep, diet, exercise, being careful about what we put in our bodies is a tremendous help going through anything. And and more doctors are talking about that with their patients, which usually didn't happen before, and it seems that lifestyle does seem to be part of the conversation, which is fantastic. And so my last question is, what's the most often asked question of you when, just in general as a doctor, what do you ask the most?
As a gynecologist?
Yes.
Am I normal? Do I look normal?
I love that. I love that. Oh my God.
Almost everybody asks it at least once.
Oh my God.
Yeah. And once they get comfortable enough, they ask, am I normal? And I think there's a lot of normal. So it's a great question. I've always laughed when I heard it. But I realize it's such an important organ, and I think it's a hidden secret.
Mm-hmm.
And I think that we all want to know, are we normal? Do we look normal? Or is it pretty? Are we pretty?
Oh my God. Wow.
Yeah, that's something that I've noticed over the last
That's
number
amazing.
of years.
That is amazing. It's so true. How do you know? You would be...
Well, you have to be a gynecologist.
And so how many... I remember when I was younger and I wanted a gynecologist, I had a choice between this man, that man, or this man. Mm. And I had wonderful gynecologists. They were terrific, I have to say. But now it just seems natural for women to go to women, right? I mean, it's a different level of conversation that I'm sure women wouldn't ask that question of a male gynecologist. I can't imagine. No, but I can't imagine.
I know it's been something that I pretty much don't talk about, but I've always laughed when I heard it and thought, okay, they want to know, and I think it's great.
Yeah, I mean, absolutely.
I think it's great to know.
And I wonder if guys ask the same question.
I don't know.
And on that note, we will thank you so much.
You're welcome.
Thanks so much.
It's a
It was
pleasure.
really great.